Good evening, everybody. Thank you for joining us tonight and welcome to another edition of Hand in Focus. The topic tonight we'll be discussing is Dupuytren Contracture. My name is Harvey Chim from the University of Florida, and I'll be moderating this session tonight with Eberlin from MGH Harvard Medical School. Tonight we'll be discussing two articles on Dupuytren Contracture. The first article is entitled Effect of Perioperative Corticosteroid Administration on Early Postoperative Range of Motion and Functional Outcomes Following Dupuytren's Fasciectomy. And we have Dr. Jonas joining us tonight. And our second article is entitled Return to Function Following Treatment of Dupuytren Contracture with Collagenase, Clostridium, Histolyticum versus Fasciectomy. And we have Dr. David Hurley joining us tonight. And tonight we have a very special guest. We have Professor David Warwick, who comes to us from the United Kingdom. He's a consultant hand surgeon at the University Hospital Southampton. He's a past president of the British Society for Surgery of the Hand, as well as the current Secretary General of the International Federation of Societies for Surgery of the Hand. He's also a world expert in Dupuytren's contracture, and we're so privileged to have him. And for those of you who do not know, currently it's 1 o'clock in the morning in the UK. So thank you so much, Professor Warwick, for joining us. So the format of this session will follow what we've done for previous sessions. We'll have two 30-minute sessions where we'll start with an author presentation, followed by a discussion from fellows from Rothman Orthopaedic Institute. Tonight we have Aaron Ollinger and Hamil Amir joining us. And this will be followed by a discussion by our expert, Professor Warwick. And then this will be followed by an open Q&A session. So again, please mute your microphones. The most important thing is please ask questions, because this session is really designed to be engaging and interactive. And we really want to make this engaging and entertaining and educational for everybody. So without further ado, I'd like to invite Dr. Madsen to start with the first paper.
Let me just share my screen in 1 second. Okay. Thank you, Harvey and Kyle, for having me. This is a real pleasure. Excited to talk about our paper. None of our authors have anything to disclose. As we all know, Dupuytren's is a progressive fibroproliferative disorder that can lead to hand joint contractures. While there are many options for treatment, surgical fasciectomy has been shown to be effective. Unfortunately, one of the issues that we encounter is postoperative stiffness. And this has kind of troubled me and my partners, where we find that there's a pretty wide variation of how people do. Some people do amazingly well and others struggle. And this kind of made us ask the question, why do some patients postoperatively get stiffer than others? And is there any way to limit this variability? And when we were talking about this, we know that perioperative corticosteroids have been shown to improve range of motion and function following other orthopedic procedures. But what really brought it to light was this paper from 2017 in JHS with terrible triads. And they did this protocol of 10 milligrams of dexamethasone IV at the time of surgery and 6-day oral methylprednisolone taper or medrol dose pack post-op, and they showed better range of motion. And after reading this article and kind of discussing it with some of my colleagues, I started doing this for my Dupuytren's patients. So the purpose of this paper was to evaluate the effect of perioperative corticosteroid administration on early postoperative range of motion and function in patients undergoing Dupuytren's fasciectomy. Basically, this was a retrospective cohort study of patients undergoing Dupuytren's fasciectomy by myself. Initially, we took a historic cohort from 2016 to 2018 that did not receive any perioperative corticosteroids. They were our control group. It was made up of 37 digits and 24 patients. When I started doing this in August of 2018, we started grouping these as the corticosteroid group. And these patients all received dexamethasone 10 milligrams IV intraop. And then starting on post-op day 1, they received a medrol dose pack that they took for 6 days. And this group was 51 digits and 34 patients. We had some exclusion criteria, so we excluded any thumb contractures because we felt they kind of had different results. Patients who were on diabetes, we thought that was a contraindication to giving the corticosteroid, so they didn't get any. And patients with less than 6 weeks of follow-up. So those people were excluded. Our primary outcome measures were range of motion, DASH scores, and complications. Initially, our demographics are very similar. As you would expect, this was, the patients all were kind of in their 50s to 70s with 80+% males. When you look at the preoperative range of motion measures and DASH scores, they were very similar, all within, within degrees of each other. Interestingly, at post-op week 2, we saw a pretty substantial, significant difference in flexion. So in all the finger joints, metacarpophalangeal joint, PIP, and DIP joint, there's improved flexion for a combined improvement of about 35 degrees. And the DASH score was 18 points lower. As we followed this out, at 6 weeks, the differences started to get smaller. What was significant at 6 weeks was PIP flexion, which was 7 degrees greater than the control group. But the DASH score kind of held strong with a 16-point difference or less. In terms of complications, we had 9 total, actually more in the control group than the steroid group. 6 wound dehiscences, which interestingly happened more in the control group. 1 hematoma, 1 suture abscess that resolved with oral antibiotics, and 1 unspecified corticosteroid intolerance where the patient stopped the Medrol dose pack 3 days in. In terms of limitations, this is not a perfect study. It has the limitations of being retrospective. If I could have done this prospectively, we could have looked at some other things that were interesting, such as pain, opioid use, and collected different data. It was a single surgeon study, so that has both benefits and weaknesses. It may not be generalizable, but we did limit kind of any variability to just the medication, given the protocol was the same and the surgeon was the same. And of course, this is just short early follow-up. It does not, we're not sure what happens mid and long term in terms of efficacy. In conclusion, we found that perioperative cortisone improves early postoperative flexion and DASH scores. We find that it was safe with limited complications, but further studies are needed to look into mid and long-term efficacy. Thank you.
Great. Thank you so much, Jonas. That was great. Next, I'd like to invite Dr. Oliger, who's one of the current hand fellows at Rothman, to give us her view on this paper.
Thank you. So, currently in fellowship, seeking to learn tools to maximize improvement and minimize patient discomfort. This article kind of touches on both points in the early postoperative period. Although the difference may stabilize with time, it is significant in the early postoperative period, and I think that's meaningful to patients and as a young surgeon looking at my hopeful good results. And this is evident by significantly lower DASH scores in the 2 and 6 week follow-up groups. I also think it's important that the study had no increase in infections or complications, and that this is consistent with other orthopedic literature that has already looked at cortisone and Medrol dose packs postoperatively. So for me, the improvement in the DASH in the early range of motion with a relatively low risk intervention is worthwhile, and I do hope to implement it in my future practice. Thank you.
Great. Thank you so much. Next, I'd like to get Professor Warwick, our expert, to give us his take on this paper. Dr. Warwick, please. Dr. Warwick?
Yep, here we are.
Okay, great.
I'll just get the screen share going for you, as always. There you are. Can you see my slides? You see the slides?
Yes, yes. Now we see it.
All right. Let me just make sure I've got the right thing for you. I'll tell you why. Sorry about this. It's just got to get the right. There we are. Should be a screen share now. Can you see that one? Can you see that now?
Now we see it.
You got it, right.
Yes.
Perfect. Thank you for that. Technical difficulties at 2 in the morning in England. So well, it's an honour to be invited. Thank you all so very, very much. And I'll just run through a few thoughts, if I may. I do have a couple of disclosures, which are up there for you. I've been doing Dupotrons for a long time. I was honoured to be involved right at the very beginning of what we call Zeopex, you call Zeoflex, when it was initially launched, and 1 or 2 studies thereafter. And that's led to a number of papers on Dupuytren's disease. And during lockdown, I had nothing to do really, or very little to do compared to usual. And I ended up putting all of my Dupuytren's work into a doctorate, into a Doctor of Medicine thesis. And then this year we had a paper from all around, authors from around the world in the European Journal of Hand Surgery looking at needles, which we'll come back to shortly. But here's the first paper, if I may just make a few comments really about this topic. Now, going back to steroids and Dupuytren's, there's a paper from years ago from Chim and Dr in which steroids were injected into little palmar nodules of Dupuytren's, and it looked like it softened it off. But apart from that, there's very little evidence about using steroids in the palm. But interestingly, things have changed now because there's a paper just published in the Lancet, so a pretty high impact journal, from a group in Oxford, where they've injected anti-TNF, which is a drug used in inflammatory disease. It's used in cancer. But the idea of treating Dupuytren's right back at cellular level is going to be the answer. So we as surgeons can, inject various drugs, or we can cut bits of Dupuytren's out of people's hands or pop them with needles. But one day this treatment will be either using something that we inject and at a very biological level, anti-TNF, for example. And of course, one step beyond that will be at the genetic level, where just like grey hair or arthritis or cancers or everything else, probably for that matter, will be treated at genetic level. But there is some evidence that steroids, in a way, in a pathfinding way, can be injected into Dupuytren's to try and influence the cellular mechanism of the disease. That's one of my thoughts. My other thoughts are to do with nodules in the hand, because if we're injecting steroid, for example, into a nodule, for which there's a little bit of evidence, does every acorn become an oak tree? Does every little nodule in the palm grow like this? We get people turn up the whole time, oh, my granddad, his fingers were like this, because it's a family history. So there's a lot of family anxiety with Dupuytren's. But if you've got a nodule and inject a steroid, for example, will it ever get worse? Well, actually, there is evidence that by no means do all nodules get worse. And the most recent paper here from the Netherlands, 2021, quite a long study, only 22% of nodules ever progressed in the palm. So we can reassure patients that you don't need to just treat nodules necessarily in isolation, for example, by giving a steroid injection. And that's important because, we want to reassure our patients, and wasting money on early treatment, there's probably better things to spend money on in our healthcare systems. It also means that if you're looking at studying early Dupuytren's nodules, any paper like radiotherapy or anti-TNF or injecting steroid nodules, if we repeated Ketchum's work, they're pretty underpowered, simply because if most nodules don't progress, then clearly to have a powered study means that the default is it ain't going to get worse. So that's something to bear in mind with the steroid injection right at the beginning. Fasciectomy, well, lots of ways of doing the scar. And my thoughts about this, coming towards fasciectomy then, is that nodules of Dupuytren's are stumps. A lot of people have skinny twigs, which are best suited for a needle fasciotomy probably. And some people have big fat logs, which were a great topic, a subject for Zeoflex injections, which we don't have unfortunately in Britain anymore, Europe, but big logs, or dermofasciectomy, where the skin is so involved with bark, if you like, that you probably need to replace the skin. And limited fasciectomy, at least in my practice, if you've got a skinny twig, then by and large you should be thinking about having a needle fasciotomy, because it is effective. It does come back, but it's cheap, it's very safe. Recovery is measured within days rather than weeks. But it's a normal cord where you've got pretty decent skin, it's not too contracted down, and that's the usual indication for a limited fasciectomy for me. Big fat logs, I think, should have skin grafts, which should be much more invasive with skin grafts when you think there's skin involvement, because recurrence is otherwise high. So to summarize this really interesting paper, actually, I have to say, I really thought this was a great paper, Jonas, because one of the problems is stiffness in the hand after any hand operation, and anything we do that stiffens the hand will at least temporarily put people backwards. And if we can improve mobility, that must be a good thing. And one of the criticisms might be, yeah, come on guys, it's only for a few weeks, it makes your hand freer. But actually, if you're self-employed, or if you're living alone, relying on a lot of family care and so on, even the first 2 or 3 weeks after anything we do is important. I'll come back to that in a commentary on the other paper as well. So you've shown that actually, if you give steroids, you get better movement, substantially better quick dash in the first 2 weeks. I mean, that is substantially, if you're trying to look after yourself and not rely on friends or neighbours, or if you're a self-employed doctor, for that matter, wanting to go back to work quicker, this is a big deal. This is a big deal. And even at 6 weeks, and this is a question for you later, the quick dash remains substantially better. 9 is not really clinically relevant, whereas 25 is substantially relevant. So really quite exciting results, actually. So well done on that. I've got a few thoughts then, based on your work. And as I say, early return to independent function is important. And even a few weeks means a lot. If you look at, say, for example, I broke my clavicle on my mountain bike it's 5 years ago last weekend, as it happens. And the first thing I did was phone up my shoulder surgery friend and said, I want you to plate my clavicle. I'm not going to be in a sling for weeks with a 15% non-union rate. I want to be back at work as quickly as possible, doing clinics and stuff. And I had my clavicle plated. It hurt for a bit, I have to say. But I was back doing clinics within a week. I couldn't operate for 4 weeks. But had I had a sling, you'd have been in a sling for weeks on end doing nothing. Volar plates the radius. Of course, you can use K-wires and even have a plaster for some. But actually, a well-done volar locking plate, you are back in business quickly. And so on and so forth. In fact, there's a paper there we wrote on the right-hand side on looking who's the key stakeholder. Because if you can't work or you're having carers, it's a big deal to get back to work early. So your paper, Jonas, if you can show that you can get back even in that 2 or 3 week time frame, it is actually a big deal. It is actually a big deal. May I ask questions now, or we can do this just during the discussion? How did you want to play this, Harvey?
No, please go ahead. Please go ahead and let's have the questions.
Yeah, so I'm going to ask a few questions. They're deliberately challenging, just it makes it a bit more fun, really. But my first reason is methodology and whether you can dissect the domains within the quick dash score. Because I just said it's a huge difference. And I just wonder, because quick dash is not brilliant for Dupuytrens because, well, you can always sleep, you don't get much in the way of tingling and so on. So there's quite a floor effect. 4 or 5 of the domains don't really count ever in So can you tell us which domain has really contributed to this quite extraordinary difference?
Yeah, it's a great question. I can't really, it was pretty diverse. So it wasn't like one thing that kind of created it. So it was just uniform. It didn't point to like the one question that was substantially different for all these patients. So unfortunately, it'd be great that we could have done that. I also wish, if it'd been prospective, we may have done different questionnaires. We could have drawn more of information. And that is one of the limitations with the fact that it was retrospective. But I wish I had more answers for you with that question.
Thanks. And my next question, I guess, is related to that, is that at 6 weeks, you showed a gain of PIP flexion of just 8 degrees. Now, the PIP actually is the most important joint in the ray because there's a long bone between the PIP and the tip here. Actually, 6 degrees, it ain't much, but because that long lever arm, it does actually move your finger quite a bit in terms of grip. But I'm not sure if it's clinically relevant or not. But again, it's odd that the only difference in movement is 8 degrees, and yet the movement in quick dash is substantially kind of more, really. So was it, do you think, because the 6 degrees is hard to explain that quick dash, do you think it's just the whole hand was more just flexible, it was less restrained? So it wasn't just the total range of movement, but it was the flexibility with which you got there comparing the two groups, something it's hard to pick up.
Yeah, I think that's the case. I think that what was significant at the PIP joint, but if you look at the whole finger, it was about 15 degrees, which, adds a little bit more. So we couldn't really explain this. And this got asked in the review process over and over, well, what explains the difference in the dash score? And we can't really fully explain it. I think part of it is what you were getting at, is that this gestalt of kind of early movement and then feeling better and getting there sooner. So at 6 weeks, they still felt good. That's very vague, and I can't scientifically prove that, but that's my feel. And that's kind of what I see too, not scientifically, but just kind of my feeling when we've been doing this, is these people just feel better way sooner. In terms of first post-operative visit, they feel really, really good. And I think that contributes to an improved dash score, where the motion probably is not as connected.
I'm sorry to interrupt, but I was wondering if I could add just like a related question. So in your paper, Jonas, you showed that there's a big difference at 2 weeks and a smaller difference at 6 weeks. So playing the devil's advocate, could it be that this difference just evens out over time, and they have the same outcomes? Do you have more data on longer follow-up as to whether there's a persistent difference in the range of motion over time with longer follow-up?
No, I would suspect that you're right, that over time, this does normalize. And so if you follow them further out, 12 weeks, I would expect that there would be no difference in the range of motion. I would also think that the dash score would normalize over time. But I think that this gets to the point of what David mentioned, is that, if it was my hand and I was getting surgery, I would want to feel better at 2 weeks and have that motion at 2 weeks. And then if not at 6 weeks, because there's a lot of things we do because of early return to function. So I definitely would not argue that this is going to have long-term effects. I think it's all based on the short term.
That's excellent. So really, from what I picked up, it may not just be the effect of the steroid in your hand, but we do know that if people have steroids, they just feel great. So they'll roll up their sleeves and get on with life, maybe because of the systemic effect of the steroids that you're giving them. So not just the mechanical, biological effect in the hand. Is that the point?
Yeah, and that's one of my regrets, that if I could have asked this, we've done a fair bit of work on pain, opioid prescriptions, pain management in our group, and if this wasn't retrospective, I definitely would have asked them pain, and I would have kind of recorded how much medicine they took, because what I see is that I don't prescribe any opioids for this procedure. Patients don't complain about pain. And I think that if I looked at my first 2 years to the second group, the control versus the cohort, I think that would be significantly different as well. I just didn't have that data. I didn't record it. I didn't get it. So that talks or speaks to the effect of the steroids to feeling good, because I think for sure it helps with pain. And there's other studies that have shown that, but for sure that makes a difference.
Mm. Okay. May I ask another question then? This is, again, a tricky question. It's meant to be, but we always, when you read a paper, there's the number of patients and there's a number of digits, and there's always the danger. Now, in a way, you're protected because you are, at the end of the day, just looking at quick dash and range of movement. But when we report more fingers than patients, you always wonder whether it might skew the data. If you had a couple of patients in one group who had 3 or 4 bad fingers, that can actually skew the results, because the groups may not be as equally matched as you may wish, if that makes sense. Do you think you should have just reported as patients or fingers? How would you deal with that problem?
It's hard. That's hard, right? Yeah. I mean, we could have excluded those with more than one finger, saying that they had different disease. We wanted to get numbers, and we thought that, given that think in an ideal world, if you were doing it prospectively and looking at this and randomizing, I think you would have to exclude multiple fingers. I think that's different. But that being said, theoretically, the DASH score is a pretty global measure, and the fingers, they're individualized. So I guess the finger motion, given that they're individual, would kind of be pretty reliable. I guess if one had a bad finger, it could affect the DASH score, while two good fingers. It's hard because it's a great question. It's hard to look at that with multiple fingers. What I will say is part of the reason we did this was because I was seeing outliers before, and not necessarily one finger outlier. It was just patients were outliers. And when I spoke to my partners, they were having the same thing. They just go, why does this guy just did awful after Dupuytren's? And so I think the steroids protect a little bit against that. When you see a DASH score of 9 at 6 weeks, there's really no awful patients there. And the range was narrow too. I don't have that for you there, but it was narrow. So we just didn't see very many awful patients. And I would love to say I got better as a surgeon over 2 years, but I doubt that made a substantial difference.
That's good.
There are, just to jump in, there are a few questions in the chat that I wanted to bring to both of your attention. The first is for Dr. Mattson about acceptability from the patient standpoint of the steroids. Were there side effects such as gastritis, euphoria, or any of those things? It sounds like one patient in the study self-discontinued the steroids, but is there anything else you could say or comment about that?
No, we asked everyone afterwards if they had any side effects, and there were really none of those that you mentioned. Obviously, we excluded patients with diabetes, so they did not get it. I think it would throw their sugars off. The patient who stopped, they stopped the day 3 of the Medrol dose pack. They just said they didn't feel good, but they didn't give any specifics. And by the time they'd come back, it was stopped. So we couldn't, there was nothing we could do about that. They were included in the steroid group. But no specific reactions that we knew of.
Great. The second question, which is a bit more provocative and I think interesting, is from Dr. Pinsky, who asked about whether or not you would consider a similar protocol for other hand surgery procedures, such as flexor tendon repair, proximal phalanx fractures, or any procedure where early motion is actually quite important. So is this translatable to things other than Dupuytren's, I guess, is a question.
I mean, I think it is. I mean, I think it's, we cherry picked this off the Duke group with terrible triads. I think terrible triads are similar. Some do great, some don't do well at all. And so I think you could, extrapolate this to other procedures. I really haven't, but maybe that's, short-sighted of me, but I think you could for sure.
So I know we're kind of running short on time, but if I may, Dr. Warwick, I'd like to ask the panel 2 questions, because I always learn, from asking people what they do. So my first question is, I'd like to hear from everybody, how long do you splint like a finger after surgery for Dupuytren's? So in your paper, Jonas, you mentioned that you splint them until the first post-operative visit. So when do you start hand therapy? So could you tell us your approach, and maybe we'll hear from Dr. Warwick as well?
Yeah, so I splint them in extension until their first visit, which is within a week, depending on where I am in the office and where they can get to. So as soon as 3 days, as late as 7 days, they start therapy right away at that point.
How about David? What do you do for your post-operative splinting?
No splints, no slings, lightest possible dressing. The only exception is when we use a skin graft, where I do splint for just 5 to 6 days only, and that's just with a dressing, nothing, just a boxing glove dressing for 5 or 6 days till the graft inosculates, but no, really early movement, no splinting.
So I do 3 months of night splinting only, and that's part of the way that they did it. I did my fellowship at the Mayo Clinic, and that's what they did. I don't know if there's any logic to that, but I totally agree on early range of motion as soon as possible. I also want to ask a second question to the panel, if that's okay. The difficult patients you encounter in Dupuytren's are those with like a 90-degree contracture at the PIP joint, and those are really challenging to treat because if you do a fasciectomy, there's a danger you could have a digital nerve injury. So I'd like to hear from you guys, what's your approach for those really difficult patients with a very bad PIP joint contracture?
You mean in terms of like the surgical technique, or?
Yeah, sure, the surgical technique.
Yeah, I don't. I don't really do anything different. I mean, I go slow. I do a lot of these now under local, so I still use Lito with Epi for these. I really haven't had that many troubles with kind of vasospasm and things of that nature. I think the one thing I do is if they have a bouncy PIP joint after kind of everything's released, I do put a transarticular K wire in until their first postoperative visit, so they stay dead straight for a week or so. But that's the only thing different that I do.
Mm. For me, just two tips really for the audience, I suppose. If the PIP is associated with an MP contracture, then always go proximal. You'll be surprised how often if you take the MP, there's something called a dynamic cord, which is where if you bend the MP joint down, the PIP straightens. And if you straighten the MP joint, the PIP flexes, which makes it very difficult to measure range of movement in Dupuytren studies. We always pretend to forget that point when we're doing studies with outcome. But if they're both involved, always go proximal. You'll be surprised how often the PIP may improve more than you imagine simply by going proximal. Tip number one. And tip number two for the audience would be in a little finger, something called the abductor cord. And the majority, if not the great majority of PIP contractures in the little finger start with a cord that attaches to the outer edge of the insertion of the abductor digiti minimi here at the base of the proximal phalanx. So it doesn't necessarily go across the MP joint. And if you always start proximal, you'll find there's this big piece here. There's a little dorsal cutaneous nerve runs just behind it. And there's always a plane between the main digital nerve and the dorsal digital nerve. And this thing's really quite a broad insertion here. And if you go proximal and take that off there, you'll be surprised that often as not, you'll get quite a big improvement in your PIP joint by releasing it at this abductor cord. So that's another hint for you technically that might help.
Those are really great hints. Thank you so much. So I'd like to turn the next paper over to my co-moderator, Carl. Do you have anything else to add to this, Carl? Otherwise, I guess we can proceed to the next paper.
No, I think it's been a great discussion. I think we should proceed given the interest of time. And I believe that Dr. Ammer is going to be our fellow that's joining us for the discussion. But we'll first invite Dr. Hurley to present his paper entitled Return to Function Following Treatment of Dupuytren Contracture with Collagenase, Clostridium Histolyticum versus Fasciectomy. Dr. Hurley, we'll let you share your slides.
Thank you. Give me just a moment.
While the slides are coming up, we again encourage people to ask questions in the chat. We'll try to make sure we get through them in the discussion, and appreciate everyone's attention this evening.
I apologize, I'm having just a moment's trouble here. Let me see if I can't correct this. Sorry. Worked very well when we tried it the first time around. There we are. All right, that should work. Now let me try. Too many windows open. Too many windows open.
No problem, Harvey. We'll give it another moment. I'm sure we'll be able to get these slides up.
Yep, I'm sure.
So actually, I have a copy of Dr. Hurley's slides, and I can share that if that helps.
Yeah, I've made a couple small changes, Dr. Chim. That's okay. That's all right. We can go with this. Yep, okay. That might be helpful. Thank you very much.
Of course.
Yeah, so again, thank you for inviting me to present our research. If you can go to the next slide, Dr. Chim, thank you. I do need to declare some conflicting interests. The first is that I am currently an employee of Indo Pharmaceuticals and was at the time this research was done. They are the makers of Xiaflex, and they funded this study. My co-authors, Victoria Davino and Mitch DeKoven, are employees of IQVIA. They provided the database and much of the analysis for this study. Next slide, please. I do want to, before I go to the methods, I do want to say one more thing, and that is that what I'm not speaking today, this evening, as an employee of Endo. What I tell you today is not necessarily the opinion of Endo Pharmaceuticals. So our hypothesis was that return to function would be more rapid and analgesic use would be lower in patients that were treated with Collagenase, Clostridium histolyticum for Dupuytren's contracture compared to those that were treated with fasciectomy. And in order to examine this hypothesis, we did a retrospective cohort analysis using the IQVIA real-world data. It's adjudicated claims US database. It contains longitudinal medical and pharmaceutical claims data for, and I can't see the entire screen, but I believe it's greater than 150 million. Now I can see it, thank you, patients. These individuals in the database are representative of the US national commercially insured population. It does not include Medicare. And the data captured in this database are demographics, diagnoses and comorbidities, prescriptions, and the use of medical services. Next slide, please. So we included patients that were greater than 18 years of age, or greater than 65 years of age if they were not covered by a Medicare cost plan. They needed to have at least one CPT code claim for either the use of Collagenase or for fasciectomy between 2011 and 2016. We considered the index date for this study to be the first date that a claim for either of those procedures was documented. In addition, we required them to have at least one medical claim prior to the index date for the diagnosis of Dupuytren's contracture. And they needed to be continuously enrolled in the health plan for 360 days prior to the index and for 90 days following the index date. In addition, they were excluded if they had any treatment for Dupuytren's contracture in the pre-index period, or any code indicating that more than one finger was treated on the index date. So we were looking at patients that were treated for a single finger. Next slide, please. We looked at analgesic prescriptions. We looked at PT and OT visit data during the 90-day post-index period. And we chose 90 days as the period to look at because we felt that that would be a reasonable time for return to function following surgical procedure. And also 90 days, as you know, is the Medicare global period for the fasciectomy procedure. We also looked at analgesic utilization overall and looked at new initiators, that is, patients that had not received analgesics prior to the index date. PT and OT visits were assessed based on the associated ICD code for the on the claim. That is to say, if the PT or OT visit diagnosis was Dupuytren's contracture, that was considered to be Dupuytren's contracture-related therapy. The results were that we had 15,491 patients that had either a claim for CCH or for fasciectomy. And we had 4,399 patients that met the analysis criteria and that were included in the study. That was 1,654 patients treated with Collagenase, and 2,745 patients treated with fasciectomy. Next slide, please. The baseline demographics were very similar in the two groups. There were some differences that were statistically significant, but probably not clinically significant. So, for example, the mean age for the CCH group was 59.7 years. And in the fasciectomy group, it was 58 years. That was significantly different, but obviously a year or two is not clinically significant. But there were two demographic items that may have some clinical significance and were different in the two groups. And the first of these was gender, where 81.8% of the patients in the CCH group were male. compared to 74.4% in the fasciectomy group. And also in the 12-month pre-index medication utilization for opioid analgesics. So 28.9% of the CCH group had received opioid analgesics in the pre-index period, that is prior to their treatment, and there were 38.5% in the fasciectomy group, and those were statistically significantly different. Next slide, please. So here you can see the all-cause physical therapy and occupational therapy utilization in the 90-day follow-up period. The top graph is for physical therapy. The bottom graph is for occupational therapy. And what you can see is that at every time point, except for week 13, there is a statistically significant difference between the utilization of both PT and OT for these two therapies. In week 1, there was statistically significantly more therapy provided to the CCH group. And then for every week thereafter, there was more utilization, statistically significantly so, in the fasciectomy group. Next slide, please. And this is the Dupuytren Contracture specific therapy. And we see a similar pattern here of significantly different utilization of OT and PT in the first week, with CCH having more utilization compared to fasciectomy. And the following weeks, out to week 13, fasciectomy had a statistically significantly greater utilization, with the exception of week 13. When we looked at analgesic use, we looked at both opioid use and NSAID use. And there we go. And what we found was that there was a statistically significantly greater utilization of analgesics of both kinds in the fasciectomy group. And the slides have disappeared from my screen. I don't know if I'm seeing. Can others see the slides?
Yeah, we were on the limitation slide.
Okay, very good. Yeah, so there we are. Thank you. So limitations, this is a retrospective claims analysis, which has a number of limitations associated with it. We have no information on the severity of the Dupuytren's contracture at the time of treatment, no information on the extent to which covered benefits might have influenced chosen therapy. This was a single-digit only study. There may be a bias towards surgery for more complicated multi-digit Dupuytren's contracture. These were surrogate endpoints for return to function, in particular PTOT, and there was no consideration of the financial implications of recurrence. So our conclusion was that a real-world database analysis of claims using surrogate markers suggests that CCH treatment may allow earlier return to function compared with fasciectomy in adults treated for Dupuytren's contracture. Thank you.
Great. Well, thank you for that presentation. I'd like now to invite Dr. Amar to just discuss this for 2 minutes, and then we'll go on to Professor Warwick.
Hi, thank you for the paper, Dr. Hurley. I think this paper talked about something that we all intuitively knew, that with Dupuytren contracture, the use of the CCH injection is going to have less pain, and thus, because of that, you'll use less pain medication. And then when looking at physical therapy and occupational therapy, because it's not an open procedure, the patients will also likely require less physical and occupational therapy. I think this paper did a nice job bringing a real life application that we can discuss with our patients. So for me, the way that I might use this paper in the future, in my future practice, is if a patient asks about real life examples of how having one option or the other, whether the injection or surgery, I can quote this paper and say that there was real life data, collected, which compared the use of physical therapy and occupational therapy in patients who underwent CCH injections versus the surgical fasciectomy that showed that they required less of that. And in addition, similar to pain control and the use of pain medication. So I'll be able to quote a real life example of how those two factors can be used as a surrogate for return to function quicker. Thank you.
Excellent. Thank you very much. Now, Professor Warwick, we invite you to give your commentary, please.
Thank you. I'll just go for the screen share again. It should work, I hope. There you go. Can you see that?
Not just yet, but here it comes.
How's that?
Perfect.
Perfect. Right, let's race through this slot. So again, thank you very much for the that's interesting. Why is it not? I'm so sorry, it's not advancing at the moment. So the second paper, returning to function. Now, we talked earlier about needles being important, and I don't know what it's like in the USA, but coming out of COVID, we have got waiting lists which are enormous. And anything we can do to keep people out of hospital is going to be a good thing, because we can then free up the operating space for other procedures. And let's face it, with Dupuytren's, a slightly bent finger that doesn't hurt and hardly causes much trouble is not a good use of healthcare resource. And so if we can treat this condition more simply using needles, that's a socially and economically responsible thing to do, particularly in this sort of post-pandemic congestion of surgical resource. And that was the gist of this paper. Now, we try to use more and more needles now, but you've got to tell your patients that it's always a trade-off. And if you use a needle, you'll get better quicker. It'll cost somebody less money, whether it's the taxpayer in Britain or you yourself in the United States or whatever. And a needle, quite frankly, is safer. Surgery is dangerous. And we heard from Kyle's paper from Jonas's paper that, from time to time, surgery does badly and we don't know why. The other thing is recurrence. So a needle is much more likely to come back because you haven't changed the biology. You've still got bad cells left in the finger and those cells will come back. Whereas if you do surgery, at least to some extent, you excise the bad cells. So needles are a trade-off, but it's something that I think we should be doing a lot more of. We do have data on recurrence. After needle fasciotomy, it's very, very high. There's a boomerang with a boomerang coming back. Fasciectomy, it depends on the definition, but skin grafting, if you do it thoroughly, right the way around to the mid-axial line, so complete preaxial amputation of the soft tissues, just leaving the nerves, blood vessels, and tendon and sheath, the recurrence rate will be low because there are no bad cells left. It's as simple as that. We also have some data on return to work. Needle fasciotomy is pretty quick. Surgery takes longer. Skin grafting probably a bit longer. And again, maybe if we all give steroids, we'll get that return to work quicker after fasciectomy. That'd be a good outcome measure for if Jonas does his paper again. We call it Zeopex, you call it Zeoflex, we say tomato, you say tomato, and so on. But if you want to look at it, it's a surgical drug. We sort of think it dissolves the cord rather than a surgeon removing it. Unfortunately, Endo has removed it from the whole world apart from the United States. There are reasons for that, which I won't go into, but that's a shame. Which cord used to have Zeopex in my practice? I did 600 Zeopex injections before it was withdrawn, so a lot. Now, I would use it for what I would call a normal cord. The cord's too fat for a needle fasciotomy. If it's skinny twig, I'd use a needle fasciotomy. But if it's too fat for a needle, but the patient doesn't want surgery for obvious reasons, then that was the perfect patient for Xiaflex. A twig, use a needle. There's no difference. And a big fat log, be careful. Don't waste time doing even fasciectomy. Get rid of that bark. Get rid of that horrible involved, thick, fat, constricted skin because you will get a better result. The therapists find it easier and it won't come back. So let's just come on, it's jammed again. I'm sorry about that. It's why is that jammed? Let me hurry up with that. So Zeopex had advantages. I mean, it was effective, high patient satisfaction. There were complications without a doubt, but they're rare. But you can see one or two there that I had, and we've published a few papers on CCH. You can see them there. We also did this. This was my medical student for his project about 5 years ago, and he looked at satisfaction. In fact, he won the editor's choice that month for the best paper in that edition of the American Hand Journal. But basically, most people preferred Zeopex to surgery, as you can see there. And the satisfaction rate was high, and it generally correlated with recurrence if they had poor satisfaction. So it's a good drug. Now, Zeopex theoretically was a surgical drug, and we always just say, it's a surgical drug, this is how it works. It cuts the whole thing out and it gets rid of the collagen, and then your body dissolves the collagen. Well, is that actually true? We thought it was true until 4 separate papers came out comparing needle fasciotomy with collagenase, and all 4 of them showed exactly the same thing, that the initial correction and the rate of recurrence were the same in either a needle or with the drug. So the concept of a surgical drug excising Dupuytrens is not true. It doesn't actually get rid of those bad cells. They're still there, and it will still come back if it wants to. We'd like Zeopex back. David, please. We can get it. There's a funny import system where we can pay a lot of money and buy it through a reseller. But, you know, for that patient whose cord is too fat for a needle, fasciectomy, but doesn't want surgery, and let's face it, that's probably most patients, it's a great concept. This paper, well, the concept is that those treated with CCH need less analgesics and SOT than those having surgery. Well, that's interesting. By extension, that might translate into earlier return to function, which we've discussed all evening is a good thing if possible. I've got a couple of questions, if I may. First of all, how reliable are the surrogate markers? Because it just seems to me if you have less analgesics, or if you have more analgesics, you may actually get back to function earlier because you've got the painkillers on board, rather than thinking that you're not. Because what we're looking at here is not, if the analgesics work, you may actually go back to function quicker because you take analgesics, if that kind of makes sense. And similarly, if you have lots of OT visits, it may be that because you've had surgery, you tend to have a lot more OT visits, and actually you might do quite well with OT visits because you've got a physio bullying you and teaching you and guiding you along your path. So that's my first question. And my second, I'll ask it now, is simply, was there incomparable data? Because by and large, CCH is very expensive, and if you've got more than one area, you may actually only partly treat a cord with CCH, whereas with surgery you can take the whole thing out, so you may actually have a bigger procedure. So they're my 2 questions, please, David, for you, and I'll exit my presentation now.
Yeah, so I think those are great questions, David, and the answer I have is to say you've pointed out 2 weaknesses of the study. We don't know how reliable the surrogate markers are. It was simply our hypothesis that those could be used as surrogate markers for return to function, but nothing in our work has validated that. And as far as your second question, I think we did control that somewhat by looking only at patients that had a single finger treated. But to your point about the financial differences that exist between surgery and Xiaflex, I think that we did not control for that. And I think that is a potential influence on choice of therapy, and then consequently on potentially on outcomes. So I think you've pointed out 2 significant limitations in what we did.
Great. I wanted to ask a question for both of you, actually, and we were kind of discussing this earlier prior to coming online, but I wanted to ask about patients that you have treated that have had surgery or fasciectomy after receiving collagenase treatment. And, you know, there's some debate about how that affects subsequent surgery, but Dr. Warwick, do you want to comment first about your experience in the patients you've treated that you've gone on to operate?
Yeah. So Kyle, I mean, you've written yourself on this. I wish I'd written that paper, but it seems to be different. Some people you operate and it's fine. The tissue planes are still there and it's easy. But I have to tell you, a couple of my most memorably hideous, difficult operations have been post Xiapex. One guy comes to mind who'd had Xiapex 3 times and had surgery, and it was the most difficult operation I've ever done. And all those tissue planes that I talked to you earlier about this beautiful abductor plane here. Have a look next time when you operate. It's beautiful just here. But those planes just go because you've dissolved it away. And that's one thing. The other thing I might say is that when I first started Xiapex, Carl, we did what you're told to do, which is just inject at one point and you put your entire bolus in one point. What we did over time was use the whole vial, so a bigger volume, and go as diffuse as we could throughout the finger. And I don't know, but I think that that's a big difference. If you start to inject it in multiple aliquots, you kind of really do change the anatomy of the whole finger, whereas maybe if you do what you were told to do with the initial Optec, just one spot, then perhaps you get less of a diffuse disruption. But yeah, it can be really difficult and it can be very easy. It depends.
Dr. Hurley, any comments about that?
Yeah, I don't really have anything to add to that. I think that sort of the jury's still out in a general sense as to whether it's harder to do the surgery post Xiaflex. But what I would be interested is, Dr. Warwick, was there any correlation between the number of fingers that were treated and were you reoperating on the same finger again with Xiaflex, or that had been treated with Xiaflex?
So there is a recurrence rate with Xiaflex, and you can reuse it when suitable. I can't answer any of those correlations because all I've got is my clinical experience. I didn't sit down like Kyle did and actually more systematically. So all I've got is anecdote for you, I'm afraid, David.
All right, thank you.
There is one question in the chat, and that is that a number of patients after Xiaflex did their own manipulations while playing golf or other routine activities. Do you think that the difference in return to activities can be explained by a difference in restrictions related to the procedures after Xiaflex versus fasciectomy? Dr. Hurley, any thoughts?
Oh, I'm sorry. I zoned out there for a moment. Let me look at the chat quickly. And maybe Dr. Warwick can answer quick first if he would like.
The question was really, some people actually do their own manipulation, which in Britain was a disaster because we get paid for the injection and we also get paid for the manipulation a day or two later. And if the patient does it themselves, that used to cost me £100 or something for not having it anyway. So yes, that's a disaster, Kyle, when that happens. But maybe you're selecting different people. Maybe people who you see people who choose Xiapex, maybe people that want to get back to work quickly. They're self-employed and they've, whereas maybe if you choose surgery, you don't care if you're off work for 6 weeks because maybe you've got people to look after you. Maybe your job is crap and you get great benefits and you don't have to go to work for 6 weeks. So, I definitely found, again, it's anecdote, but that the people who choose Xiaflex are kind of, on average, maybe different from people who choose surgery. Therefore, they may be more motivated or whatever to get on with it.
And the only thing I would add to that is I don't think we have any data on how many patients do sort of self-manipulate. So I think that it's a little difficult to determine whether that's a factor in this data that we presented. My guess is it's not a lot, but I may be wrong about that. That's just a guess.
Great. Harvey, do you have any other comments or questions yourself?
No, that was a really, really great discussion. So I just want to end by just sharing some slides. So again, now CME credit can be claimed for Hand in Focus. Credits can be claimed once every 6 months for all AHS webinars, and watch for an email around November of this year to claim your credit. And again, thank you so much for your participation. Please follow AHS on social media. Candidate membership is free. And please follow AHS on social media and watch out for the next Journal Club. And finally, I just want to extend a thanks to all our panelists, particularly to Dr. Warwick. I think it's 2 o'clock in the morning in the UK now, right? So I'm surprised you're still awake. I will be asleep by now. You know, we really value your insights. Yeah.
Thanks
So
very much. It's a pleasure.
absolutely. And thank you so much, everybody, for joining us. And please join us for the next Hand in Focus. Have a good night.
Have a good evening, everyone.
Yep. Good night, everybody.
Good night.